The management of rectal cancer, a modern multidisciplinary approach. Welcome to today's podcast, where we will be taking an in-depth look at the management of rectal cancer. Over the years, the approach to treating rectal cancer has undergone a remarkable transformation. What was once a process focused solely on surgery has evolved into a sophisticated system that brings together a range of experts. This multidisciplinary team includes surgeons, specialists in medical oncology, radiation oncology, radiology, and pathology. The fundamental aims in managing rectal cancer are to achieve a cure, preserve the function of the rectum and genitourinary system whenever possible, and to reduce the risk of the cancer coming back locally. To begin, it is important to note a key anatomical difference between rectal cancer and colon cancer. The rectum is situated deep within the bony pelvis, which complicates surgical procedures and has historically contributed to higher rates of local recurrence. Initial evaluation, laying the groundwork for treatment before any treatment is considered. Precise staging is absolutely essential. This step determines the pathway that will be followed. The evaluation process starts with a physical examination of the rectum, which helps to assess the position and movement of the tumor as well as its relationship to the sphincter muscles. A rigid scope is often used to accurately measure how far the tumor is from the opening of the anus, which is vital for planning. Advanced imaging plays a crucial role, with a higher resolution magnetic resonance imaging scan of the pelvis serving as the cornerstone for local staging. This imaging allows for assessment of how deeply the tumor has invaded the rectal wall, whether the tissue surrounding the rectum is affected, and if lymph nodes are involved. It also determines whether the sphincter muscles are involved, which in turn influences whether it is possible to preserve them during surgery. Scans of the chest, abdomen, and pelvis help to identify whether the cancer has spread to distant organs, such as the liver or lungs. For very early tumors, an ultrasound probe inserted into the rectum may be helpful in assessing how far the cancer has penetrated, especially when considering less invasive surgical options. Blood tests, including levels of carcinoembryonic antigen and a complete blood count, are routinely performed. Finally, a tissue biopsy confirms the diagnosis and includes testing for mismatch repair status, which has important implications for prognosis and the choice of therapy. Tailoring treatment strategies by stage. Once the stage and risk factors have been determined, the team develops an individualized treatment plan. For early-stage rectal cancer, meaning tumors that are small and have not spread to lymph nodes, the primary treatment is surgery. For small and low-grade tumors, local excision through the anus may be appropriate. This approach avoids major surgery but comes with a higher risk of the cancer returning locally, since lymph nodes are not removed. For other cases, the gold standard is total removal of the rectum and its surrounding tissue, which includes lymph nodes. This operation can be performed through the abdomen, restoring the bowel's continuity, or, in situations where the tumor is very low and involves the sphincter muscles, it may require a permanent colostomy. The most common presentation of rectal cancer, however, is locally advanced disease. These tumors have invaded deeper tissues or have affected lymph nodes. Here, a multimodal strategy is essential. The standard care involves a combination of chemotherapy and radiotherapy before surgery, followed by additional chemotherapy afterward. The radiotherapy is delivered over several weeks, with chemotherapy administered at the same time to enhance the effects of radiation. This approach shrinks and downstages the tumor, increasing the likelihood of a complete removal and significantly reducing the risk of the cancer returning locally. Surgery is typically performed several weeks after the completion of chemotherapy and radiotherapy, allowing the tumor to respond as much as possible. The operation again involves total removal of the rectum and surrounding tissue. After surgery, patients usually receive several months of chemotherapy, depending on their recovery and the extent of disease prior to treatment. A newer approach has emerged for patients with higher-risk locally advanced disease, known as total neoadjuvant therapy. In this strategy, all chemotherapy and radiotherapy are administered before surgery. This sequence can vary, but the advantages include better patient compliance with chemotherapy and higher rates of complete response, where no viable cancer cells remain in the tissue removed. For patients who achieve a complete clinical response, there is potential to avoid surgery altogether, embracing a watch-and-wait approach that spares them from surgical risks. When rectal cancer has spread to distant organs, the goal shifts from cure to palliation. The aim is to prolong life and manage symptoms. Systemic therapy involves combinations of chemotherapy drugs, sometimes paired with targeted therapies or immunotherapy, especially for patients whose cancer has particular molecular features. Radiation may still be useful for controlling symptoms like bleeding or pain, and in select cases, surgery may be considered either for palliation or, rarely, with curative intent in those with limited metastatic disease. Surgical principles and techniques. The technique of total mesorectal excision, which involves precise dissection around the tissue surrounding the rectum, has dramatically decreased local recurrence rates. Preserving the sphincter muscles and avoiding permanent stomas is a major goal, and advances in surgical methods have made this increasingly possible, even for very low tumors. Minimally invasive approaches, such as laparoscopic or robotic surgery, are now common in many centers. These methods offer equivalent cancer outcomes, with the added benefits of quicker recovery, reduced pain, and less blood loss. The robotic platform is particularly valuable in the confined space of the pelvis. In cases where an anastomosis, or surgical connection, is created at a low level, a temporary diversion of the bowel through the abdomen may be performed to protect the healing site. This diversion is usually reversed after a few months. Surveillance and long-term care. After successful treatment, patients enter a follow-up program designed to detect any recurrence or new cancers. This includes regular medical history reviews, physical examinations, and blood tests for carcinoembryonic antigen. Imaging scans are performed for several years, and colonoscopy is scheduled at 1 year and periodically thereafter. Summary and future directions. In summary, the management of rectal cancer exemplifies the power of precision medicine and multidisciplinary collaboration. Treatment pathways are determined by careful staging, with magnetic resonance imaging playing a central role. For early-stage disease, surgery remains the mainstay. Locally advanced cases require a combination of therapies before and after surgery, and in metastatic cases, the focus shifts to systemic treatments and palliation. Looking ahead, the field is moving toward greater personalization. This includes refining strategies for patients who respond completely to therapy, tailoring treatment intensity based on response, and integrating new biomarkers and blood-based tests to guide decisions about additional therapy. The development of more effective drugs for advanced disease also remains a high priority. Through this comprehensive, stage and risk-adapted approach, rectal cancer has been transformed from a condition with high rates of recurrence and morbidity to one with excellent chances of cure and improved quality of life. Thank you for joining us in this discussion, and we encourage you to stay informed as progress continues in this important field. If you enjoy our content, please like, share and hit the subscribe button. It's the Everything Surgery Podcast. Dissect the extraordinary.